Okay, good afternoon, everyone. My name is Susan Barrett. Welcome to the second installation of the 4 ISF series calls. We are so happy that you have joined us. It is 2 o'clock Eastern Time. We have about 90 minutes to share together this afternoon. Just as a couple of housekeeping pieces before we get started, I want to make sure that all the participants on today's call know that we have muted your line to limit background noise, but we really want you to contribute to the dialogue today by asking questions in the chat box. So we've got a chat box over here, and you can ask questions as you go through, and we'll have a couple of people monitoring the chat so we can make sure that we are stopped and clarifying any kind of questions that you might have. We are also going to be recording today's session, so Colin, if you could start the recording, please. We want to make sure that even though you haven't been able to participate or you have others that are interested in participating through these webinars, that you have an opportunity to go back and listen to them even if you can't participate in a live version. I have put the, we did already have one webinar with ISF, and I've put the link to that recorded session in the chat box so you can download that as you need to. We will also send out a follow-up email and prompts and reminders throughout this time that we have together to make sure that you are continuing to get the information you need. So for today's call, we are going to continue our conversation with integrating school mental health through a multi-tiered system of academic and behavior support in schools. Last time we did an introduction and we highlighted the work that's going on in Pennsylvania, and our presenter Kelly Perales outlined some of the ways that they are installing ISF in the districts in Pennsylvania. On today's call, we are highlighting the work in New Hampshire, and so we are going to be hearing from Michelle Myler from the Department of Ed in New Hampshire, and we're going to be hearing from Joanne Malloy from the University of New Hampshire. Before we get started and having our exemplars present, I wanted to kind of go through an outline of what we're going to cover today. We want to kind of go over our professional learning community and review the purpose of our learning community, and also invite you to participate in our ISF targeted work group, and we'll go over that in just a couple of minutes. We wanted to provide a quick review of ISF and the whole installation of mental health in schools. Again, we're going to highlight the work and the progress that's going on in New Hampshire at the state level. And then we want to open it up to some dialogue and answer some questions, make sure that we're meeting the need as we all kind of embark on this journey of ISF. Just to kind of give you a little bit of a background with our learning community, we have, as we mentioned before on our calls, have an ongoing group of people that are participating in this work at the school, the district, and the state level. And we have a professional learning community where we have been meeting on a regular basis and learning more about how different folks around the country are installing ISF. It's been really helpful to hear a range of examples from our sites who are using and refining the tools as they're getting developed, and really kind of helping us pave the way for really describing and articulating what the process looks like and sounds like. We also are providing materials and resources to be able to share with each other within our community, and we're always open to feedback and suggestions that you have for us along the way. During this learning community, we do have a couple of important dates that are coming up. We're going to make sure that we get June 2nd on your calendar. This webinar will focus specifically on the role of the school and community-based clinician. And so we will be talking in a lot more depth and detail about the changing role of the clinician and some of the changes in job descriptions and some of the ways that we're using clinicians differently than we have before. The other date we want to have you keep in mind is the August 11th date, and we are going to be talking about the ways that some of our sites are integrating restorative practices in schools, and we will also have another exemplar participating during that webinar. Additionally, we wanted to invite a smaller group, a targeted work group, to participate in a couple more calls. We have some additional dates that we're providing below. We have June 30th, July 30th, and August 28th. We really want a smaller group to participate in serving as knowledge development sites or being able to apply ISF and blending our system of care sites within education. And so we would like a smaller group to contribute to the writing of a short technical brief and really kind of give us ongoing feedback about the way that it's operating inside your school, both the strengths and some of the challenges that you're experiencing. If you do want to participate in this targeted work group, we do have some guidelines that might help you think about the task at hand. We would want you to invite a small team from your site that includes someone in a decision-making role with the authority to align funding, change job roles and functions, and shape the policy. So we really do want that decision-making person to kind of be and participate on the targeted group calls with us. We'd also like you to identify 1 to 2 schools that serve as one of your local demonstration sites and work alongside our work at the district and community level to make sure that we're learning about what it looks like and sounds like at the school level while we are creating the pathway and developing the structures that support implementation at the school level. Finally, in our work group, we really want you to document your effort by answering questionnaires that we will have along the way, and again, contribute to the development of a technical assistance brief that allows us to look at the ways that we're blending PBIS, mental health, and system of care. I really appreciate the fact that we had 13 of you so far respond to our survey, and we will be, once we get more numbers, we will be sharing the results of that survey with you. So if you are, once again, interested in the targeted work group, we ask that you reach out and email. You can email me specifically. We'll set up a call to figure out the ways in which we can support you, and then we'll ask you to participate in those additional calls. So to get us started and to make sure everybody is able to kind of connect with us today, we want you to, once again, ask where you are employed and positioned. So are you working at the school district or other agency, or are you working with a mental health agency, child welfare, or other community-based agency? And so I see that most of you are already submitting your responses, and we'll give you a couple minutes to do that. Excellent. Wow, this is great. It looks like about 60% of you are coming from a school district, and oh, it's changing. So I'll give you a couple more minutes here. Okay, it looks like 64% of you are coming from a school district or education agency, and 36% of you are coming from a mental health community-based agency. So thank you. Colin, can we go to the next poll, please? And what category below best describes your role? Are you serving as a school administrator, community agency administrator, school or district-based clinician, community-based clinician, family representative, or classroom teacher? We'll give you a couple minutes to respond to that. I feel like we have to have music in the background as everybody's responding. I promise I won't provide that for you. Okay. Thank you very much. It looks like we have a range here. We have mainly school administrators, and it looks like followed by community agency administrators, some school-based clinicians and community-based clinicians. So we really have a all right, let's go back to, now that we know who is here today, let's go into reviewing some of the big ideas coming from ISF. And one of the things we want to start with is this notion of well-being. And I have a couple of questions here that kind of have been resonating with educators across the country as we go and talk more about ISF and the ways that we're connecting mental health and school success. And so should the central role of education be building and improving well-being? And how would academic achievement improve if we had students, youth, educators in environments that fostered emotional health and well-being? And so one of the big pieces that we're describing when we describe ISF is this notion of equal priority, that in order really to have some of the outcomes, academic outcomes for our students, we really have to start paying more attention to fostering the emotional health and well-being of our students. And we really need to pay attention to our adults working with our youth and our students and make sure that they have the skills and the supports that are needed to do this complicated, complex work that we're doing with our students and our youth. The other aspect of what we're wondering is, what impact would that have on healthcare? What impact would that have on so more of the larger societal outcomes, like in the justice system? What about the impact on poverty and homelessness and drug use and abuse and long-term unemployment? And if we can really pull together a way that we have equal priority for overall emotional health and well-being in addition to academic success, then we're really starting to see huge changes that could be carved out that would impact larger society outcomes. And so some of the major features that we are installing with ISF come in part from the multi-tiered system of support. And the core features outlined here are really the starting point for a lot of our schools and our school systems as they start to blend school mental health and get that broader range of depth and quality. It really starts with the following core features: an investment in prevention, screening, and early intervention for students that are not at benchmark. This idea that we are looking at schools and organizing how we approach supports to students through that multi-tiered lens, and making sure that we are progress monitoring and problem solving across all three tiers. We also want to intervene very early on and never let students have the opportunity to fail. So we are screening kids with lower thresholds. So when they are in need of additional support, we are in a place where we can provide that very, very quickly. Other core features include making sure that we are paying attention to a small number of research-based practices that are actively being used across the tiers. So often we are invested in many, many practices and innovations within our organizations and our schools, and sometimes that waters down our ability to be able to provide that with high quality. So we really want to invest in, what does the research say about this practice? Is there evidence behind it? And we also want to be sure that just because it has evidence doesn't necessarily mean that we need to install it. We have to have a more rigorous and formal approach to determining what practices will meet the needs of our particular students and youth, and also making sure that we have the systems and structures to support that the adults know how to implement those practices with high quality. We're also going to be making sure that we've got a data system that really allows us to capture that quality of implementation and allows us to see that the students are successful with the interventions that we're putting in place. And if we don't have success, how do we augment or change that to make sure that we are reaching those successful skill sets that we want to make sure that we're building as we move through the process. So again, going back, and I know that this is an overview for a lot of you, but we wanted to make sure that we are all kind of grounded in these core features. So PBIS really is a decision-making framework. What we love about PBIS is its flexible nature. The schools decide and select which best practices will improve academic and behavioral functioning for the students that they're serving in their local community. And we have a very specific guiding resource that gives our schools and our communities kind of that step-by-step process by which they select and implement. We also are providing tools to schools. We have data. We're focused in on database measurable outcomes. We want to make sure, again, that the work that we do has outcomes for kids, investing in that evidence-based practice, and then supporting our adults and supporting and making sure that those structures are there to support that alignment. We know based on our randomized control studies that we are seeing some benefits. So when PBIS is in place with Fidelity, we are seeing that there are reductions in problem behavior, increased academic performance, increased attendance. We are seeing increased perception of safety, reduction in bully behaviors, improved organizational efficiency, reduction in staff turnover. And then when we're polling and asking our teachers the impact, they are saying that there is an increased perception of teacher efficacy and improved social emotional confidence. So we are seeing some benefits from implementing PBIS. But really, that's the foundation, and we need to recognize that many schools are struggling to implement effective interventions and strategies for Tier 2 and 3, that we have many youth with internalizing issues that are going undetected, and that the systems, although showing success for school climate and discipline, aren't addressing that broader range of community data and mental health prevention. So we know that we need to do more. And so in the development of ISF, we have really worked with knowledge development sites across the country to teach us some of the lessons and to work with them on refining the process and procedures for making sure that our school mental health and our community mental health partners are involved in that multi-tiered system of support lens. We wanted to remind you that we do have a monograph that's out that's a really valuable resource for a lot of our places that are just getting started. And while it is a rather lengthy monograph, we do have chapters that are dedicated to state-level implementation. We have chapters that are dedicated to district implementation. And finally, we have chapters dedicated to school-level implementation. And we even have data systems and practice chapters at the school level. So if you're running into a roadblock and challenge, you can just quickly go to a chapter in the monograph rather than feeling like you have to sit and read and memorize the whole thing. The initial efforts described in the monograph come from, again, our knowledge development sites in the following places across the country. We do know that the foundation, although present, we do have some complex needs, and we need to make sure that our schools, first and foremost, and our communities is serving as a protective factor, that we have the right people on our problem-solving teams and our systems planning teams that are dedicated to making sure that we've got family, youth, and community voice present in our Tier 1 and Tier 2 and 3 implementation teams. One of the things that we really are concerned about is kind of the fragmentation that may occur when we have our community providers coming into our schools and they aren't necessarily invited to the systems planning teams. We really want to make sure that we're opening that pathway up and making sure that our teams represent the entire family and community that we're serving rather than just focusing on the school community. We want to make sure that our data for decision making is broadened out, and then we do have screening mechanisms, whether that be formal or informal screening mechanisms, by which we can decide when kids get access to supports, and making sure that we're selecting the right practices based on the individual needs of our students. And finally, we want to make sure that we're layering those supports on the core foundation or the universal system, and make sure that we're layering on top of rather than creating or developing a separate system for more of our complex issues. So we want to define ISF and go over one more time the core features of ISF. Like MTSS or PBIS, it is a structure and a process with some guided processes for more deliberately making sure that our educators and our mental health providers are interacting on a regular basis and making sure that we're not duplicating efforts and we're not bumping into each other. We have to work more effectively and efficiently if we are going to get the outcomes that we seek. We also know that it needs to be guided by a range of stakeholders and that our educators alone can't change some of these paradigms. And so we need to make sure that our mental health providers and our community providers are right alongside us inside of the teaming structures that we've already developed. We also need to make sure that we've got the right people who have the authority to reallocate resources and change the role and function of staff, change job descriptions, be able to change the policy and make sure that best practices are being adapted and adopted. And so we really need those people that are making those decisions to be part of the implementation rather than outside of the implementation so they can fully understand what is going to be required to make these necessary changes. Again, ISF is going to focus on that tiered prevention logic. We're going to make sure that we have cross-system problem-solving teams, and that is that when our community health providers have training events, that our educators are present, and that when we do have trainings inside our education departments, that we're involving our community partners and we're doing that cross-system and making sure that we've got the competency across all of those domains. We want to make sure that we're guiding the right data and we're using that community data, and we're going to talk a little bit about broadening that out. And again, we've talked about that progress monitoring for both fidelity and impact and that active continuous involvement by our school and community and youth. So in terms of systems, and one of the things we're going to focus in on today is really understanding what a leadership team we really, again, need our community providers participating at the district level and developing a district level plan so that we don't have fragmented issues or practices going on in each individual school, that we really have a coordinated approach for how we're going to deliver services within the district. We want to make sure that we have a range of data, and we want to make sure that we're coordinating through the lens of multiple structures. EBPs that we're seeing in schools, and yet when we're looking at the needs of our students, we're seeing a lot more need for trauma-informed care, and so reaching out to our community partners to be able to add to the list of EBPs or making sure that our EBPs are matching the need is going to be critically important, and making sure we're tapping into those resources more effectively. So while we're able to maybe have a smaller selection of EBPs, when we bring in our mental health providers, we are able to have that broader menu. And so you'll see some of the list of that broader menu here. When it comes to school data, normally our school teams are looking at a range of data, and sometimes that can just be overwhelming, right? I mean, in addition to looking at our academic benchmark data, we're also looking at discipline data, attendance data. We're asking our schools to invest in actively looking at our a look at the nursing and social worker and counseling logs to get an indication of who's using those services that might be flying under the radar, not be picking up because they might be have internalized issues. And so they would never be picked up on by simply looking at discipline data or office referral patterns. So we're asking that we're taking a look at those logs to make sure that we're picking up on our kids who might have some internalizing issues. But this, even when we do look at this data on a regular basis and we have this in front of us, it only allows us to screen from one view. And when we broaden out our reach to our community partners and the data that we're looking at, we're able to get screening from multiple views, and we can look at some of the community factors that might be contributing to some of the issues and concerns that are going on inside the school. So we might be asking our teams now to look at food pantry visits, to look at calls to crisis centers and hospital visits in order to, again, get an idea of what our families and our communities are dealing with beyond the school day, and really set the stage for being able to plan and, again, broaden out those practices that we're installing as a result of understanding what is going on in our community. So poll 3, I have just gone through a rather quick overview of ISF, and I know that we did this during our first call, but we want to make sure that we are reviewing for those of you who are joining us for the first time. So here's another poll that we'd like you to complete. My experiences have been similar to what has just been described as the ISF approach, and there is an agree and disagree. So I'll give you a few minutes to respond to that. Also, as I'm going through and you have questions, please enter those in those chat box. We really want to hear from you and make sure that this information is resonating with you. Okay. So 86.9% of you are saying that you agree that your experiences have been similar to what has just been described. Thank you very much. Colin, if we could. Thank you. Okay. So now let's focus on the collection of tools that are being developed and refined as we move through this process. One of the tools that we talked about last time is called the Team Implementation Planning Guide. And we're going to focus a little bit more on that today. And our partners from New Hampshire are going to describe the ways that they have moved through that process of integration at the state level and how they're blending funding. And while they did not have access to that planning guide, they can talk about the ways that you might think about leveraging that guide as a starting point for a more integrated model. At the school level, we talked last time about the survey on school readiness for interconnecting positive behavior supports and school mental health. And our partners in South Carolina developed that as a result of making sure that there were certain things in place and that were present within the school and within the district before moving forward with connecting mental health and PBIS. And so we will focus on that survey during another call, but wanted to make sure that you knew that that was available to you if you wanted to take a quick look at that prior to us diving more deeply into that one. The other school level measure that we are refining is something called benchmarks of interconnected systems. This really allows us to check for fidelity across tiers with installing ISF. For those of you who are familiar with PBIS and have used the benchmarks of quality, this is an enhanced version of that. And again, we're still moving through building the psychometrics for this tool and are very interested in your feedback about it. So if you're out using it, we would love to hear from you about ways that we can improve that. The last school level tool that we discussed last time that we'll go a little bit more into today is the consumer guide for selecting evidence-based mental health services within a school-wide framework. And so once again, this will really lend itself to that conversation about installing a formal process by which a district or state selects practices that their schools are going to implement. And again, I worry that we've got kind of this magic fairy dust approach to selecting practices that we install in schools, and sometimes we don't have those rigorous kind of methods by which to say, you know, is this something we really need? Is this something that's going to benefit? And what's the research or evidence behind it before we kind of move forward? The other thing I really worry about when we're selecting practices is that we're not considering the ways that we're going to build local capacity to make sure that we're not over-relying on external providers and wasting money in that way. And so we really want to make sure, again, that we are focused on making our educators and our mental health providers better consumers of what's available to us out in the field. And so the consumer guide is one way of formalizing a process at the district and state level to guide us and making sure that we're putting the best of what we know to be working with our kids inside of our schools. The appendices within the monograph will give you those tools so you have everything available to you. And once again, if you decide that you're going to be using them in the schools or the districts that you're working with, please give us feedback on the ways that you're using them and improvements to any of the tools that we have. The other piece about the appendices that you need to know is that there are a lot more tools that are available to you. We don't want to overwhelm you, but we want to make sure that you know that you've got access to all of this. Additionally, the monograph will give you information related to specific sites across the country. And so if they match your demographic or you feel like it's a good fit, it might be nice to kind of dig deeper, and we can get you in contact with those sites and you can have conversations with them in order to kind of learn more about what's going on in their sites. Okay, so before I hand it over to our New Hampshire folks, I just want to quickly go through the District Community Team Implementation Planning Guide. Much of our work is complicated, and sometimes it feels pretty enormous undertaking to put two systems that have been working in parallel universes together. And while we can talk about it at the surface level, it's a completely different thing to change the way we work on a day-to-day basis. And so in order to kind of set the stage for making this more doable, we are really anchoring our work in the phases of implementation. This work comes out of Dean Fixon at the National Implementation Research Network. And so we want to make sure that we're anchoring our work with each phase of implementation. When we provided that survey for you, the 13 folks, and thank you once again for completing that survey, the 13 folks self-identified as being in exploration stage when it came to developing ISF. And so again, one of the ways that we're using this is making sure that we have a single implementation framework, and if we started with PBIS, how do we really enhance and organize that to make sure that we're hitting other domains like academic and like mental health, and how do we use that single framework as the way of work no matter what domain we are hitting? The other piece of using this tool, we need to have the right people at the table when you're using this tool. So that will, and our folks in New Hampshire are going to talk about the people that are currently serving on their team and how they've positioned those people to best fit where they need to go next. And the other purpose of this tool is to promote the policy and allocate the necessary resources. You know, again, one of our worries is that folks are getting a grant, they get access to a little bit of funding to move them forward, but after the funding goes away, so does the new work that's been developing. And so we really need to be thinking about building capacity, building sustainability mechanisms right from the get-go as soon as the grant hits the ground. And so one of the ways that we can do that is through looking at policy, reallocating resources, taking a really close look at our job descriptions to make sure that there's the right match, and making sure that we're blending funding sources and that we're setting the stage for a climate that where we feel like we can flex out the funding somewhat and people don't feel like they own certain funding. We also want to make sure that we are developing an implementation plan that focuses on increased access to services and ensures the right resources and staffing are in place. And so that's kind of the purpose of making sure that, or the purpose of developing this, this instrument and tool. And again, it's a work in progress. And we're hoping to hear from you about the ways that you are utilizing it and the ways that we can improve it. So as a way to kind of connect some of these tools with work that's being done out in the field, I want to introduce to you Michelle Myler and Joanne Malloy from New Hampshire, who are going to talk about the ways that their state has blended some funding sources and given the opportunity has now a team in place that's really kind of setting the stage for a more blended model and approach in New Hampshire. So Michelle, I'm going to turn it over to you.
Good afternoon. I'm Michelle Myler. I'm the project coordinator for Safe Schools, Healthy Students initiative called New Hampshire Communities for Children. And I work out of the New Hampshire Department of Education. And what I'm going to do is give a brief overview of our project to set the context for later discussion of how the implementation framework for this project is ISF. So the New Hampshire Department of Education received an $8.6 million grant funded by SAMHSA of the Department of Health and Human Services. And the purpose of the project is to improve mental health outcomes for students and to create safe and supportive schools and communities. This is a 4-year grant from September 2013 to September 2017. These funds support a coordinator and a co-coordinator at the Department of Health and Human Services Bureau of Behavioral Health. And those two positions work directly with the Safe Schools, Healthy Students project director and the project coordinator at the New Hampshire Department of Ed, really to provide the oversight for the project. We do have a memorandum of understanding between the DOE and DHHS. 75% of these funds go directly to 3 pilot sites, which are 3 school districts in our state: Laconia School District, Concord School District, and Rochester School District. Excuse me. So here we see the governance structure for the Safe Schools, Healthy Students project. And at the top you see the state management team, which meets monthly and includes over 40 members representing education, behavioral health, which includes mental health and substance abuse, and criminal juvenile justice agencies. And as you can see, this really is about bringing together these systems to do cross-agency work by enabling us to work on systems change and to bring this really to scale across the state. Then underneath, you can see that in each pilot site or school district, there are community management teams, also made up of cross-agency and cross-disciplinary representatives with work groups or subcommittees that support the collaboration and the implementation of the project throughout their district. Each district underneath, as you see, has PBIS leadership teams at each of their schools. So Safe Schools, Healthy Students project is guided by 5 required elements, and then we have our own goals under each element. And I think this is important for some of the later discussion that we'll be getting into. How to ISF is really the guiding framework. Project. So element 1 is promoting early childhood and social emotional learning and development. Element 2 is promoting mental, emotional, and behavioral health. And the goal for this element is really to improve the mental, emotional, and behavioral health functioning of all students by facilitating access to relevant health services at every tier along the continuum. Element 3 is connecting families, schools, and communities. Element 4 is preventing and reducing alcohol, tobacco, and other drug use. And our goal in this element is really to build the protective factors and student resiliency and decrease risk factors. And element 5 is creating safe and violence-free schools with a goal to increase safety and protective factors, improve measures of positive climate and culture in 50% of the participating schools. So all 5 elements really are related to the interconnected systems framework as it relates to good practices, but really it's the guiding framework for elements 2, 4, and 5, which you will learn more detail about in Joanne's presentation. But before that, the steps that each pilot site took towards implementing ISF at the school district level I felt was important to highlight. Some of the planned activities included interconnected system framework professional development opportunities, and not just for school district staff, but really for all stakeholders and partners, including community mental health, early childhood, family and youth stakeholders, and other community providers who participate in the initiative. at the district and the school levels, which is important, as Susan had mentioned, to have those people all at the table when creating these plans. And then consultation with the Institute on Disability at the UNH at University of New Hampshire on development and implementation of ISF, and then training and coaching from the New Hampshire Multi-Tiered Systems of Support Collaborative. Also at the district and the school level throughout the project, as well as ongoing TA provided throughout the planning, the implementation, and the monitoring phases. Additionally, each school district held day-long interconnected systems framework workshops that the state supported and planned and implemented this in collaboration with each of the school districts. And this invitation was open to district staff, community partners, including the community mental health centers. At these workshops, we were honored to be able to have Joanne Malloy from the Institute on Disability at UNH and Lucille Eber from Midwest PBIS Network and National PBIS TA Center present on ISF in schools and really lead in the action planning activities. Throughout this work, each district created a district-level PBIS leadership team to plan, implement, and monitor interconnected systems framework across the district for the duration of the project. So, like Susan said, there is a coordinated approach, and this all came out of those day-long workshops that we were able to host. So it's really important to have a really strong and solid foundation for the framework to ensure that ISF is implemented with fidelity and with the support of all the partners in the initiative involved in these planning pieces and TA. So that's really, it really is a collaborative approach here in New Hampshire, and like Susan mentioned earlier, it's essential for there to be a structure and a process and to be guided by the key stakeholders that we're all at the table and will continue to be ongoing throughout the project. So I just wanted to stress that how important that these planned activities are and were in adopting and implementing the ISF model through this project. So that's my overview, just to set the context, and I'll hand it over to Joanne Malloy, who directly supports our pilot sites in the implementation and monitoring of ISF, and she'll give some more specific examples of what that looks like in specifically one of our projects.
Okay, thank you, Michelle. What my role with the projects is to help several of the schools with TA around positive behavioral interventions and supports and implementation of PBIS, but also in bringing the mental health supports to the table and working together to create a seamless system. And as Susan said, you know, we can't afford for schools to be developing staff who become experts in high-level evidence-based practices for children with significant mental and behavioral health issues. So the need to collaborate with community mental health providers is important. So what we see with the Safe Schools, Healthy Students initiative coming out of the Substance Abuse and Mental Health Services Administration is a real recognition that schools need to create a continuum of evidence-based supports, and that mental health supports in particular and behavioral health supports in general in order for children to be successful in schools, and that the community mental health community is recognizing that a system of care framework where school is a key, if not the primary environment for the delivery of EBPs and evidence-based prevention, early intervention, and tertiary supports, it brings together the needs from the mental health community, and schools are converging, that they both recognize that they need each other. So what we have in New Hampshire is a nice model where we're looking at primary prevention, creation of school-wide classroom systems for all children that are evidence-based, and where mental health clinicians can actually play a role by being members of the team and the school-wide leadership team, and provide in-service training for all teachers on trauma, provide training for all families and students on behavioral health and good mental health, We find that the mental health clinicians can also play an important role on secondary prevention. In other words, small group practices and interventions for children and youth who are struggling in school. And then, of course, they play a very important role in the one-on-one tertiary interventions for children and youth who have significant mental health challenges. So the use of the ISF has been very helpful, but is different for our mental health partners than typical practice, although the system of care framework talks about a public health model, which the triangle is. Many mental health clinicians and agencies are still in the fee-for-service medical model, which is all individually based services and supports. So it's a different way of thinking for our mental health partners. Now, what made the ISF such a good framework to blend with the Safe Schools, Healthy Students framework was the idea that these 5 elements that Michelle talked about earlier made perfect sense to use the ISF framework as a way to implement those elements. In many ways, they can seem like disparate elements from one another unless we use a public health model. So what has happened in New Hampshire is element 2, there's a memorandum of understanding between the community mental health centers and the school districts that are part of the Safe Schools, Healthy Students framework. And that memorandum of understanding states how the mental health center will be engaged with the school's PBIS or public health framework. So it's designed to create a collaborative relationship and not just a handoff of a child, not just a referral, but the features of the MOUs include the fact that clinicians sit on district and school-level teams to be experts and consultants to help with screening and communication. These are not the kinds of activities that typically community mental health clinicians can engage in because their reimbursement doesn't typically allow for it. So these MOUs and the Safe Schools dollars have allowed the schools to be able to engage their clinicians on their teams as experts. And by being members of the teams, the clinicians can see the entire context where students are being served in each school. And the clinicians are supported by the district to help plan and provide school-wide and small group evidence-based interventions such as I said before, education for faculty and family members and students on trauma-informed care, co-leading small groups, developing functional behavioral support plans for non-mental health eligible students, in other words, for kids they can't bill for under typical means. And they may design a facilitated referral process, which means we know that a lot of times parents are urged or counseled by the school staff to apply for mental health services, but we also know that that application may not happen unless it's a real collaborative approach where perhaps the clinician can meet with the family even before a referral isn't made, or the school staff can gather more information for the clinician so that referral really actually happens, and it happens in a family-friendly, youth-friendly way. So let me just use the Concord School District as an example of a memorandum of understanding that really speaks to what we really want to see between the mental health center and the school using the ISF framework. First of all, Riverbend Community Mental Health will provide clinical and administrative supervision to Riverbend staff who provide services in the Concord School District. So the supervision will be specific to that context and to the different problems that the clinician is bringing back to their center around barriers and issues. The clinician will participate in school-based teams, as I was saying earlier, facilitate school-based psychoeducational groups to promote social, emotional, and mental health, so preventive activities to really help children and youth and their family members understand what good mental health looks like. provide consultation on children and young people who are really struggling and be a resource for the staff. They'll also provide feedback to help staff as they problem solve around particular behavior plans and service planning, help with parent education activities, serve as a liaison with the mental health center to facilitate those referrals we were talking about before, adhere to relevant school confidentiality regulations, and a lot of times this requires HIPAA and FERPA kind of compliant documents and working those things out between the two different agencies. And of course, exercise ethical judgment and complete a monthly activity summary so that the school can see what's happening and collect data around what's happening with the mental health center. So this particular MOU is very, very specific around what the mental health center will do. And then in exchange, the district says, we'll provide administrative contact. In other words, you don't have to talk to 15 people. We will have a coordinating piece so that your work in our school is more efficient and effective. We'll provide you space, internet access, and so forth, so the clinician can actually be in the school and work out of the school. Collaborate to assess effectiveness of services, because we are talking about outcome-based supports and services, and support the purpose, mission, and work of the clinicians. And so this is really an illustration of how very, very intentionally and carefully they've mapped out the roles of the mental health center and the roles of the school within the ISF principles and values, the values that we know are very consistent with system of care values, which means data-driven, outcome-driven, family-driven practice, and culturally competent practices. So this has really been an important opportunity for the school and the district to work together, and the district can still bill Medicaid or private insurances as usual for all other supports that they have provided. So we really would love to see you talk a little bit or put in some questions or comments about what you think about this, but certainly a district-level community team with membership from the mental health center has been really advantageous with the Safe Schools grant, so that the mental health center can talk about barriers that they have and the district can talk about barriers that they have and begin to problem solve. And there could be a real advantage to using the district community implementation planning guide to enhance this kind of deliberate relationship via an MOU between a district and a mental health center. Does anybody have any comments they'd like to put in the chat or any questions?
Thank you so much, Joanne and Michelle. This is incredible. This is Susan. I'm wondering if you could talk a little bit about who the people were that contributed to the MOU, who the roles that they serve on that team.
In Concord, it was the assistant superintendent, who was the original director and wrote her portion of the Safe Schools grant, and now each Safe Schools region has a project coordinator who actually writes and oversees and manages that MOU. And then the children's director from each mental health center is actively involved from the mental health perspective.
Awesome. And it sounds like the MOU was really that leverage and that kind of end product to have some of those necessary conversations and dialogue around funding, around repositioning staff. Would you see that in terms of phases of implementation as something that you would do in installation phase? In other words, did you have a lot of dialogue prior to getting in the room and hashing out the specifics of the MOU?
Well, the beauty of the Safe Schools Healthy Students projects, and there may be some people listening who are Safe Schools sites, is that the funder, SAMHSA, does not want to see any services implemented until a plan, a district and community-wide plan and logic model are created. And so which I think is smart. That's your engagement kind of exploration phase, exploration of what the needs are. So SAMHSA required a fairly rigorous process where all community partners had to work together and then prioritize the needs. So it wasn't just that everyone dove in and started to pay for services. It was a very deliberate process using a logic model.
Great. And how long did that take you all to move through?
Well,
it was a good year, wouldn't you say, Michelle?
Yes, a year.
Yeah, it was the first year. So it was, although it was, we have a kind of a grant approval process that made it actually a little less than a year here. It was a very intense year when we used community level data like you talked about earlier, Susan, youth risk behavior survey data in each school, existing data on suspensions and other kinds of behavior data, kids who are incarcerated. We have 2 of our regions are resettlement areas, so looking at high need populations. So it was a very intensive and deliberate process, as I say, and it kind of brought the community mental health perspective and the school perspectives together, where they talked a lot during that phase.
Well, I think that's really important to kind of have folks that are just starting this process recognize that a full year of really intensive, deliberate dialogue is a lot of time. And sometimes I think it's important for us to kind of assess the length of time it takes for the right people to come to the table. And recognize it is very hard work. Yeah, definitely hard work. And a grant helps in the writing of the grant, the actual planning and development a grant, like say Schools Healthy Students is important. And I know on the call we have a lot of folks that are currently involved in Project Aware, and I know SAMHSA has the same kind of guidelines in terms of making sure that there's a planning process, a logic model in place, and that they're prioritizing needs. So just because you don't have this type of grant doesn't mean you can't use that same process, and it seems like that end product that was really valuable is the MOU. I want to just quickly read the chat for folks. Thank you so much for interacting with us today. I know it's challenging when we have muted everyone's line. Anne has a question. She says, are the clinicians part of the school behavioral mental health team of clinicians?
I'm not sure what a school behavioral health team of clinicians might be, but the community mental health clinicians are members of the, if you will, a Tier 2 planning team or implementation team where they're looking at data along with other school members and designing interventions matched to student need.
Yeah, okay. So it sounds like, I think that's a Pennsylvania term. So I think for the most part, we're making sure that the clinicians are part of that systems planning team.
Right.
A lot of times the clinicians that come to our schools kind of hang a shingle, have an office space, but we're never really sure as teachers what's kind of going on behind the scenes. And so this allows us that clinician to have kind of, as Joanne described, that full context of how students are behaving in the education setting and arena, and also kind of help generalize and maintain the skill sets that are being provided in the individual sessions to the teachers. So having them serve on that systems planning team is going to be really essential, and being able for the district to kind of navigate through that fee-for-service model that oftentimes prohibits that access to be serving in that way can open up the pathway to make sure that they are getting paid for serving on that team. Frank Wright, really, yeah. I'm sorry, go ahead, Joanne.
No, I'm looking at some of the comments, and that is what we're looking at down the road. We've just adopted managed care, although it's not really taken hold as a bundled rate the way it should. Our mental health centers are still on a fee-for-service system, but if we eventually do go to a managed care kind of case rate, I'm hoping we can prove cost effectiveness so the managed care companies will allow the clinicians to sit on systems planning teams.
That's awesome. Yeah, that's our hope when we talk about positioning people at the district level that can change that that's who we mean. You know, we really need that flexibility for people to serve on the various teams and not be locked into just, quote, seeing kids, that there's much more to that job to be effective and efficient. Let's see. I'm just looking at the chat box. Can you please comment on how this process may work in rural areas where resources are limited in large geographic areas?
Well, Michelle we'll get a chance to know pretty soon because we have 3 new districts coming on, and two of them are way up north. So we'll let you know.
Okay. Yeah, keep us informed.
Yeah, this is Michelle Myler. I was just going to say we will know as we move along with those 3 school districts who received Project Aware, but we were happy that the rural school districts did receive the funding to be able to adopt this same model and supports, because obviously the resources are slimmer there. But I think, again, going back to how to make this work when you're bringing all the people to the table and giving yourself enough time to create a strong foundation for interconnected systems framework is coming to the table with people and having the data there, the risk factors in the communities, which obviously being in a rural area, you'd have a lot of those risk factors right there. But getting those people at the table and giving yourself enough time so everybody can adapt and talk about how to change the way that they're working so that they can meet the needs of the students in the rural community. But it does prove to be trickier because resources are slimmer than obvious barriers for students, like transportation and things like that, which can obviously be built into a model like this.
Mm-hmm. Yeah, it's very challenging. Karen says, my agency has had the opportunity to conduct a blended funding arrangement whereby the school kicks in funds and insurance is billed through MA. We also have few contracts that are fully district funded, permitting, and I don't know all these acronyms, and the HTs to be fully integrated to the school environment and reach out to the family. So you guys have worked out a blended funding arrangement, which is beautiful. And I think that's the trick. That's what we're really trying to do in exploration, is find out why we can't get to deliver some of the services we want to because we're binded by kind of the rules and constraints of the rules that don't allow us, to implement things with that best practice. Mm-hmm. Okay, so I've got one more. Ann says, PA has a very rural district and they're doing some very creative things. The county system of care brought in the National Implementation Research Network to present their providers on implementation science. So even though they have a large community, they're focused on sustainability. That's great. And again, I think that the work that we've done in PBIS and the National Implementation Research Network and the scaling up really sets the stage for those critical structural pieces to be there and as anchors to really fully integrating and blending different disciplines into that single framework that's being described. So that's awesome. I'm going to move us forward. I want to quickly review the consumer guide because the next piece that we're going to have Joanne and Michelle talk about is the range of evidence-based practices that they have in their model. And so I just want to make sure that folks are aware that this consumer guide exists and that there's a process and that you can go through with your district team to talk about the ways of, developing a formal criteria method by which we are selecting the services that we provide to our students. I know that in some of the surveys that are coming back to us, folks are kind of saying that principals have the authority to be able to select things on their own, and a lot of times the district has no knowledge of what's being adopted at the school. And so one of the things we're trying to do is really have a much more formal process and be consistent across the school so we don't end up with 15 and 16 different initiatives that end up getting completely watered down because no one can do those very effectively. Furthermore, we've been kind of sold this curriculum or a book that ends up sitting on the shelf and doesn't really get implemented with that quality because again, our educators and our clinicians are completely overwhelmed by the numbers. So this consumer guide is there to kind of promote this formal process for selecting these range of evidence-based practices. I talked about that. And then just to make sure that you guys know where to find the evidence base, again, don't go to a website and see that something that you might be interested in has that stamp of approval that says evidence-based. You want to make sure that you're going through one of the American Psychological Association website or the National Institutes of Health or the Colorado website, What Works Clearinghouse. These are all places to go where you're going to get peer-reviewed kind of lens on what's working, because we want to make sure that we're investing in stuff that's likely to work. Typically, we're seeing 14 separate programs. Again, the idea is that we've got to really stop doing the things that aren't making the impact for our kids. How do we collect the data to look at fidelity and outcomes? And if we're not seeing the outcomes, we really have to stop. We get caught up, and this is perhaps one of the most challenging things that our districts and our schools have a tendency to keep on doing all those things, thinking more is better, and we really, again, have to promote this idea that we invest in the smallest number of practices that yield us the outcomes that we seek. So there is a selection process and considerations, make sure it's culturally appropriate, make sure that the developmental level, and make sure that we've got the expertise, the skills that are required to implement with fidelity, that we are training and supporting and coaching our staff to deliver those effectively. So again, this tool is really nice to be able to guide you through that process and have your district community team really have serious dialogue about the way in which you're moving throughout this process. So again, I'm going to turn it over to New Hampshire to talk about the example at the school level about how they adopted their program and kind of the benefits of that. So Joanne.
Okay, thank you. I have been providing support to Runlet Middle School for almost 4 years now, so I'm pretty well versed in what they've been doing. And what I'm going to talk a little bit about is how Safe Schools, Healthy Students has had a positive impact on their ability to expand their range of interventions. So you can see, and I appreciate all the comments in the chat. It's great stuff and great stuff going out there, which is why it's nice to have a community like this. But you can see that we're not hugely diverse in Concord, New Hampshire. But as I was saying before, there's a growing new immigrant, new American population, and many of those families have come here under difficult circumstances. So they've done a nice job in Concord at addressing the needs of that population. But Runlet is a fairly large middle school with 1,000 students, grades 5, 6, 7, and 8. So they began implementation. They have a fairly active universal system with all the required features, including a rubric for social emotional expectations. And they had a very active Tier 2 team, systems planning team before they started, but they revised and re-energized and redesigned their Tier 2 team when PBIS came to be, and identified themselves as the team that provides additional over and above the universal interventions for students who need more than just the universal system, and also be a support for faculty. So they identified themselves as the team that identifies the needs, behavior support needs of students, and then designs and implements, oversees implementation of interventions for those students. So over time, we've been able to build a fairly robust group of interventions, and this pyramid changes from year to year, and depending on the student population. Some interventions come in, some go out. What you will see here is primarily evidence-based interventions. The beauty of the Safe Schools model, one of the beauties, and I'll give a shout out to SAMHSA again, is they require, if you're implementing a Safe Schools project, that you use evidence-based interventions. You can go off the list if you need to, but that you must have a good rationale if you're using something that doesn't have a gold standard evidence base to it. So what they've done here is create a list of universal interventions for every student, additional interventions for students who need more, and then very high-need students receive individualized interventions at Tier 3. And this is kind of used as their guiding rubric, with mental health support at all 3 tiers. So I'm just showing this as the Runlet Tiered Fidelity Inventory. In the past, we would use the SET with this group and the team implementation checklist, but now with Safe Schools, we are using the Tiered Fidelity Inventory, and you can see that the most robust work is being done at Tier 2 within Runlet Middle School. This guides the team's work in terms of developing systems and overseeing their systems. And they have written nomination criteria for Tier 2 supports that are measurable. And I borrowed Susan's phrase, natural screeners, if you will, as much as possible. They did do a teacher kind of assessment or sort of internalizing and externalizing behaviors, but generally nomination for Tier 2 is absences, tardies, dismissals, ODRs. They also look at nurses' visits to try to find those students who are quietly not doing well, too anxious to go to class. They look at academic failure, counselor visits. And they were also looking at kids who were kind of hanging around in the office, asking to go see an assistant principal or a counselor, and then lingering in the office maybe 2 or 3 times a week. So they had several of these kind of screeners to identify their Tier 2 group. And then they implemented check-in, check-out, and are in their 3rd year. Many of you are familiar with check-in, check-out, a highly researched intervention. And they have a fairly robust system that they have redesigned from year to year, and they've learned a great deal about it. Currently this year they have almost 40 students, I believe, in check-in, check-out. They really identified that students appeared to be acting out to obtain in-school suspension or recovery room time, so they began to look at, okay, is the recovery room too good of a place to go, and do we need to change the way that room appears? They had students asking for homework help, students who were disorganized and internalizing or externalizing their behaviors. The school psychologist did some research, and we worked together to identify the behavior education program from Jessica Swain Bradway, and they designed it to become an academic seminar class with where students with executive functioning issues could go to get homework help, organizing help, and set goals for themselves. So that's what this class is. This class is not a gold standard EBP. It hasn't been subject to randomized control trials, but it does have the features of an EBP with good fidelity measures around behavior support. In other words, helping students to find the kind of support they need for executive functioning issues. Last year, about a year ago, the behavior intervention team noticed that there was a small group of students who really seemed to have a lot of anxiety, some of them could perform academically, but they were asking to leave classes. And for me, as a high school person, the piece I really had to get used to working in a middle school was the fact that you could actually go through a class, and having to pass the class wasn't as high stakes as it is in high school. So these were students who really spent a lot of time in the office, were going to the nurse too often, had a lot of unexcused absences. And the school psychologist went online, connected with people in her network, and found that Coping Cat was an evidence-based practice that she felt might be worth identifying for students who had stress-provoking situations and high reaction to stress. And so she started to look at it last year, and then as this MOU evolved with Riverbend Counseling, she found out from talking with them that they had trained clinicians who used Coping Cat in the mental health center as a community-based intervention. And so she asked them if they would partner with her to run Coping Cat groups at Runlet Middle School. And so what this does is allows for a trained clinician to partner with the school counselor, and they co-lead these modified Coping Cat groups. And I say modified because Coping Cat is designed with a family component, a parent component, and they weren't using that component in this pilot. They have called this, and I would call this a pilot of Coping Cat. They ran 2 small groups for 8 weeks. And they used a pre-post measure, which is an evidence-based measure called the SCARED, oddly enough, Screen for Child Anxiety-Related Disorders. And the groups were co-led with a mental health clinician from the Community Mental Health Center and a school counselor. And this is what they saw for outcomes with the 18 students. There were 2 Coping Cat groups. On items on the SCARED. There was an improvement in anxiety. A reduction is a good thing in the anxiety scores. And you can look up the SCARED. It's available online. They looked at absences. Now, interesting enough, during the Coping Cat, the absences went up, but they are seeing some good retention post-Coping Cat of reduction in absences. Reduction in nurses' visits, again, unusual. They went up during the Coping Cat groups, but have now gone below pre-Coping Cat. And then here's a case example of one 8th grade female student where her SCARED went down, which is a good thing. This says attendance. These are really actually number of absences. Her absences went up a little bit during Coping Cat, but have gone down. And her nurses' visits have gone down. Here's a 6th grade student who didn't have a better score pre-post on the SCARED, but she does seem to have better attendance and isn't using the nurse as much as she was to get the what she needed in terms of support. And here's another female 6th grader who they had seen some good outcomes with. Good reduction in the SCARED scores, pretty good reduction in absences, and wonderful reduction in nurses' visits. And that's good for the nurse, too. The nurse doesn't have to spend as much time. Now, I wanted to show the pre-post student report because, like any good data report, the team is now looking at, okay, Coping Cat worked to reduce anxiety for most kids, but not all. So why didn't Coping Cat work for student number 18, student number 7? What's different about those students? So right now, the team is in a kind of reflective mode where they're looking at what worked and what didn't and what needs improvement. And the clinician is on the Tier 2 team that's making these decisions. They also are realizing that they need, you'll see under bullet number 3 here, they need to engage teachers to reinforce the skills that are learned during the Coping Cat sessions, much like parents are supposed to be engaged in the formal version of Coping Cat. In this modified Coping Cat, we need to engage the teachers so the teachers can know what the students are working on and reinforce those skills. So what they're going to do next fall is offer Coping Cat sessions daily instead of once per week so that they hope there'll be better generalization of skills in the classroom, because that's the idea, is to keep the student in the classroom. and they are going to continue to co-lead the groups with a community mental health clinician and a school counselor. So meanwhile, while this is all going on, a school counselor is building their fluency in Coping Cat, the Coping Cat intervention. So they didn't actually use the consumer guide to come to Coping Cat, but they are going to in the future. I've shared the consumer guide for choosing practices. They're actually looking and researching at evidence-based small group interventions for youth who engage, students who engage in externalizing behaviors, looking for a good anger management and anger skill development intervention that they can deliver in the exact same way. So this is just one example of how the Mental Health Center and the school work together, and they're getting pretty good outcomes for using a modified evidence-based intervention. So I'm going to kind of turn it over to Michelle and Susan now, because there's been a lot of good chat in the chat room, which is excellent, and hopefully we'll be able to capture that because all of you have wonderful experience, and I know some of you, and you have terrific experience, so thanks.
Wow, thanks, Joanne. Michelle, I wanted to give you a chance to add anything to the conversation before.
Hi. I don't have anything to interject at the moment. Actually, I enjoy seeing the detail of how this is fleshing out at the schools, and you know, Joanne's working directly with the schools on that. And again, you know, the state supports the A3 pilot sites, and you know, like providing them the professional development opportunity that we did in January, the workshops on interconnected systems framework with Joanne and Lucille and partnership, and we support them as much as we can along the way. So at this time, I don't have anything else, but I appreciate it. There's been some side conversations that I've been tapping into over here, and so I'm good. Thank you.
Great, thank you. And you know, this example was such a beautiful example. It was just exquisite. I was getting really excited because you really just demonstrated kind of the identification of a need based on data, right? And then you went into selection that matched the need. You looked up to see who the community providers that could possibly have the skill sets already that could help promote that. And then you talked about looking and reflecting on the data in order to adapt and change to make sure that you were meeting the need across all of the students. The other thing I liked about what you said is you're building capacity. Your school counselors are in a position now where they're increasing their skill sets. And so you hit every single mark in such an elegant way, Joanne, and I really appreciate that as an example of how we're putting that consumer guide in place. And although you didn't have a consumer guide at the time, you hit all of the marks in terms of what we need to see when folks are moving through that process of deciding what they're going to put in place. So well done. Really appreciate your time today. I think it was hugely beneficial to kind of hear again from the field about how we're installing ISF and the ways and approaches that are really yielding outcomes for a broader range of kids. So thank you very much for that.
Susan, I wanted to say one more thing.
Okay, go ahead.
I just want to recognize Donna Pally, Stacy, and Margie Baraska needs a shout out. Although this is school vacation week here, she did all this work, and she is like a school psychologist of your dreams because she really put Coping Cat into place. And so I know she's on vacation this week, but I really want to make sure that people recognize her, and you can email her if you want to know more because she did a beautiful job on this.
Excellent, excellent. Yeah, I'm sure there's a huge number of people that are involved in this work, and so we really appreciate the shout out to all the work that's getting done inside the schools. It's absolutely amazing. So congratulations on that, Joanne. And yeah, we're all cheering. I can hear our silent cheers in the chat box. And just to let you know, we will be providing this PowerPoint presentation for you in the recorded session. We have a list of all of your information as you're registering for each of these webinars. So we want to make sure that in addition to being able to contact the presenters that you're hearing on the webinar, you also have access to these PowerPoint slides, and please use them back at your sites to kind of demonstrate the impact that other places are having. I know that we're running out of time, so I just want to make sure that everybody has additional dates on their calendar. I want to promote the 20th Annual School Mental Health Conference that's occurring in New Orleans, November 5th through 7th. And a lot of breakout sessions include information related to selecting evidence-based practices, screening, formal screening procedures in addition to informal screening procedures. And we also have a huge strand on ISF, so just a big shout out to that conference and the ISF strand. So if you're interested in learning more and working with us face-to-face, it's always nice to kind of see folks there. Ooh, this one doesn't look very good, but at any rate, we also have another conference in Chicago, October 22nd and 23rd. This is put forward by our National Technical Assistance Center, our PBIS Center, and we are going to be talking about integrated multi-tiered framework for educational success and featuring mental health integration and the work that's going on in ISF along with other topics that you see here. So save those dates. We'd love for you to join us. And then one more time on the other dates that we have moving forward. Again, June 2nd, we're going to be highlighting the role as a school and community-based clinician. You do not want to miss that webinar. There's some exciting, guiding processes that we're using to really change the way that we're positioning clinicians inside of our schools, so it's incredible. And then August 11th, integrating restorative practices in schools, and we'll hear about things that are going on in Illinois with respect to making sure that we are installing that within a multi-tiered system of support and not kind of removing PBIS in order to put restorative practices in place. And I think that that'll be a good demonstration of how we're blending that and installing it within the MTSS framework. So that's all we have today. If you have any questions or concerns, I'll go back, see if I can go back to I guess I can. I'm going to put my email in the chat box so that you can contact me. Again, we're interested in those targeted work groups. So please feel free to contact me after the call. We will be sending not only the PowerPoint and the recorded session, but we'll also be sending that request to complete the survey. We really want to hear from you. We want to get more information about what it is you're doing and making sure that we're meeting the needs during these webinars for you. So with that, I am going to say farewell and thank you once again to our New Hampshire partners. Joanne and Michelle, that was brilliant. We really appreciate your time in sharing all the great work that you're doing in New Hampshire with us today.